And who would have thought that managing the borders would be considered so vital and so prominent and so fascinating. So thank you for the amazing work you've been doing. Being a professor, I can't say anything in under 50 minutes, so I'll try to guess that. So, yeah, a site with it. Okay, so just to all of us have survived this pandemic, but also the previous pandemics, 2009, SARS, another coronavirus, being affected New Zealand, and I actually got really interested in public health, and I switched from clinical medicine at the tail end of the HIV/AIDS epidemic, because I thought I'd have a year in Wellington working in the Beehive, one of the ministers, on a few projects, and then going back to Auckland, back to medicine, and then I just found it so fascinating, the systems approach. And the thing I got involved in was setting up the needle exchange program, and this was the first national program in the world, and it just showed me that good science combined with courageous leadership makes a huge difference, and I think New Zealand has a track record of doing this, as we have during COVID-19. Slightly erratic. See. Okay. Oh, there we are. So I'm just going to run through a few things like sizing up pandemics, the elimination strategy, its impact, where we're going from here, what we think the future looks like, and then the things I'm really interested in discussing with you is, I think, some critical issues around protecting us at the borders, and also some of the, I guess, how an epidemiologist looks at the world, which is all around the population perspective, and it is different sometimes. So just to remind you that the core idea is epidemic, that's more than you expect. We have lots of outbreaks which are small and localized. Occasionally we get a pandemic which is widespread, and it doesn't have a precise definition, just lots of places. And so don't worry about all the details there, but this is saying that there is a framework for looking at things and working out how bad they're going to be. We care about transmissibility, severity, can we control it, and what resources will it require, and then how certain are we about the information. And this can be a problem because sometimes there's too much certainty, and we saw this across the Western world. They had said, this is an influenza virus, we're going to just wheel out our influenza plan and that will work. And that was turned out to be a terrible mistake for assessing this risk properly. So this is where you need modelling, because you can't say, oh, what happened last year was a new disease. You have to look at what it might do. This is where you put parameters into a model. We did the initial modelling for the Ministry of Health and said this will kill about 13,000 New Zealanders, about 0.3% of the population, making it the biggest human disaster since 1918 flu pandemic, which killed 9,000 people in 6 weeks, half the number who died in the entire First World War. So another key factor in New Zealand is inequalities. This is showing a century of the extra risk for Māori of dying from influenza pandemics. And you can see even as recently as 2009, the risk of death was around 3 times higher than Pākehā majority. So we know pandemics amplify inequalities. So just thinking about, this is either hugely patterned by age, the risk rise enormously from getting age. And I think one of the strangest phone calls I got was from the New York Times on the 2nd of October, and they said, Trump's got it, what's going to happen to him? And I thought, firstly, why are you ringing me in New Zealand about this? Because I've done a few interviews with him. And then I gave him the conventional answer. He's 74, he's got borderline obese BMI, so there are risk factors, but he'll probably survive because the risk of death is about 12% in an age group. After I finished the report, of course, I remembered what I should have said. Well, he's got very low income, 750 in federal income tax. It means puts him in a high risk group. And what I would wanted to have said was that hopefully his impending eviction from the White House means to be homeless. But of course, I never thought to say that at the time. So, as you know, one of the huge revolutions which added to the tools for understanding pandemics is genomics. And it's really amazing, the insights, and this is showing that New Zealand was seeded with viruses from all over the globe. We really had the whole diversity of genotypes. But one of the remarkable insights that's not immediately obvious from looking at cases is that only 1 in 5 cases creates much ongoing transmission. So it's like throwing a 5-sided dice, and 1 out of 5 times you're going to get an outbreak. And so that's why, as we all know, not every case results in an outbreak, even if you think it should have. And obviously that's enough to propel us around the globe, even those odds are still in favour of the virus. So I don't know if you're like me, you remember when you first heard about something, you thought, I need to hear about this thing. Epidemiologists get paid to worry, so we were worrying quite early in January, a novel coronavirus in China, what could go wrong? But by the end of January, it was clearly going to be a global pandemic. And then there was a bit of good news by the end of February. This report from China, the joint WHO-China report, said it's been stopped in Wuhan. And no one's ever done that before, that stopped a pandemic on full flight. And so that convinced people like myself we could contain this thing and actually elimination was possible. I actually thought every country in the world would follow that model because it was a joint report. It was up on the web. It said you could stop it, but they didn't. So by mid-March, and the next insight for me anyway was that we had to go into lockdown as fast as possible because we did not have the infrastructure. After decades of underinvestment, we could not stop the virus with testing and contact tracing. So this is going back to the most basic infectious disease epidemiology. If you're trying to, we'll ignore no strategy, don't do anything which applies to things that have low impact. But after that, you've got a fork in the road. You either control them or you eliminate them. Control, you could have mitigation, which is a light touch, and that's what was in our pandemic plan, or you can suppress, which is more intense. But elimination, that's reducing to 0 in a country. And that we have elimination strategies for several diseases, polio, measles, rubella, and a few others. There's nothing exotic about that idea. It's just that it wasn't being applied anywhere in the world to COVID-19. And then the much tougher bar is global eradication. That's reducing to 0 across the world. And that, unfortunately, has only really ever been done for smallpox and one animal disease, brain pest. So I certainly became convinced that this was the optimal approach. We wrote, I think it's still the world's first elimination strategy, and we talked intensely with the government about this. And New Zealand effectively adopted this approach, although they didn't use the word eliminate for a few weeks for various reasons. And we all know that amazing day on the Monday, the 23rd of March, the government says, we're not just going to ramp up the alert level system gradually, we're going straight to the highest level as fast as possible. We've only got 100 cases, no deaths. And across the world, people were astounded at that because no country was doing that at that point. So just back to, so you find it very hard to read the back of the room, but so you have to believe me that this is the number, the reproduction number. Who's very familiar with the reproduction number now? If you put your hands up on, this is a scientific survey here. So, I mean, a year or two ago, people never heard of the reproduction number, and that's just, as you know, the average number of secondary cases generated by each case. And if you can get that down below 1, the outbreak fizzles out. Above that, it's exponential increase. And there's only 3 things we can change: transmissibility by doing things like physical distancing, reducing or wearing masks, I should say, reducing contact rate, that's people staying at home, and the duration of infectivity, the third part of the reproduction number, we can't alter that without antivirals or vaccines. So, you know the components of the elimination strategy, obviously keep it out, the most important, and then stamp it out. And then if all goes, if it's turning pretty pear-shaped, you can then use a whole lot of measures to dampen down transmission, masks, physical distancing, and now vaccination. And then we have a social safety net as well. So these astounding graphs, who would have, if we thought back to January last year, if you'd said to people, we're just going to stop most travel into and out of New Zealand for an indefinite period, they would have laughed at you. But this idea of 99% reduction in movements, and 1 or 2 days when no one came or left New Zealand, no one has seen that for decades. The other component, of course, is second component around contact tracing required a massive amount of testing, and a huge tribute to our laboratory scientists who really built up this capacity to a huge extent. And then the third component, dampening down transmission. And traditional measures were wrong for this disease because you can say stay at home, that's good. If you're sick, wash your hands, sneeze into an hour and so on. Yeah, it's still really good public health advice. It's just for other viruses. It doesn't work with this virus because most of the source cases are pre-symptomatic. They don't have symptoms. They're not staying at home. It's droplets and aerosols, not from touching surfaces. The only thing that dampens down transmission is mask use. We were very slow to adopt masks in New Zealand. We still haven't got a mask culture here, even though that was the absolute critical hygiene measure. It still gets very little attention, I think. That's mass masking, and obviously a huge focus on improving ventilation and filtration, which I'm sure many of you are experts in. I should say, for my efforts to promote masks, I'm now immortalised on the packaging, mask packaging, and you can buy one of these wonderful masks in cover. I don't get a cut. But, so the other thing that we all are very familiar with, the other part of dampening down transmission is the alert level system, a brilliant piece of risk communication. This is probably etched on our retinas now, the floor level system. So physical distancing, this is one of the things you can get from big data. This is showing the Oxford Stringency Index, which is the level of lockdown assigned to every country on Earth by day, and you can produce this graph in a few minutes. And the remarkable thing is, firstly, New Zealand did have one of the most intense lockdowns at the beginning. It was short and sharp, 5 weeks at level 4, 2 weeks at level 3. So basically, it's a stay-at-home order or a circuit breaker. I prefer those terms to lockdown. But it was very stringent, but over the course of many months, we've had far less time in lockdown than many other countries we compared with, like Sweden, UK and US. I mean, we are far more the land of the free than the Swedes, who seemed to at one stage thought they were. And, these scenes, Russia and the main highway into Wellington, we all saw these scenes around the country that were remarkable. And so what was the effect of these measures? This is, again, showing that we were on this exponential curve upwards. We implemented these measures, and then we saw this exponential decay in the virus, and we emerged into a virus-free country. So that's the main thing you want to see in terms of knowing if you've got it right. So one of the other indicators we've got of success is the COVID-19 mortality rate. This is deaths per million. And down the bottom, you can see countries that were very low mortality. Taiwan, China, New Zealand, Australia is a bit higher. And then it's several hundredfold higher, the risk of dying, if you're in a number of European and North American countries. So if we just took the mortality risk of Sweden, which is 0.14% of the population have died, and apply that to New Zealand at this point, that would be 7,000 deaths. So your efforts have saved 7,000 lives. And these are not all elderly people with dementia. The average years of life lost per death internationally is around 16 years. So this is, at a very crude level, this is one of the positive health impacts of the elimination approach. So one of the other things we wouldn't have, it's very logical, and this is showing mortality by month, and the fact that we missed excess winter mortality. Normally around 1,500 people die over winter from influenza and other respiratory viruses. That didn't happen. So that's another 1,500 lives that people have lived to this year overall. And our all-cause mortality is around 5% less last year than usual. So in economic terms, people felt, maybe that's not very well to do this really vigorous response, that you're going to kill your economy. And actually the reverse happened. This is a paper we published in the British Medical Journal just before Christmas, and we pointed out much lower mortality in the countries pursuing elimination and much better economic recovery. So it's a false dichotomy to say it's one or the other. So where are we going to from here? This is you probably occasionally look at these websites that give you the global picture, and it's pretty depressing with recurrent waves of cases and deaths. Up until about November last year, this was driven by the behaviour of governments. But since then, we've also seen a contribution from the virus with more infectious variants starting to magnify transmission. So in terms of what happens next, this is showing what we call the epidemic curve right up till now. And I'm sure you're very familiar with this graph. And basically it's showing that in general, New Zealand's done very well at keeping cases out. So all the blue ones are ones that were acquired overseas and are generally safely kept in your custody or care. But of course, all systems have failures, and I think it's 13 or more events where something has gone wrong and it's been what we call a community case or more cases. I'll come back to that in a minute. So we know about vaccines. There were two astounding discoveries last year. One was that simple public health measures can stop this virus. The other is the speed of vaccine development. And we've got multiple classes of highly effective safe vaccines. There are still some unknowns. We don't know the duration of immunity, which was unknowable until we have the vaccines in use for a while. How well they work against virus variants. So far they're holding up very well, and I think they can keep ahead of virus variants. And we're just waiting for the data, obviously, on effectiveness and safety in children, but I think that will come through fairly soon. So this is just a Ministry of Health graphic showing how the vaccine is being rolled out. I assume there's everyone in the room must be vaccinated now. Is that right? About? So you're first at the front of the queue for very good reasons. And as you know, you would not be a priority group in countries that are awash with the virus. So that's a distinctive feature about countries pursuing elimination. You're absolutely and rightfully at the top of the priority list. So in terms of strategic choices going ahead, there's two main choices. And you either switch to a control approach, and you say this will be an endemic infection, it will circulate in children, and we'll just vaccinate the vulnerable. It's a bit like what we do with seasonal flu, except this is a much more effective vaccine. So that's option one, suppression, endemic infection. The other is we continue with progressive elimination. And that's what we do with measles anyway. It's not unusual to do that. And we even think about global eradication as happened with SARS. It might take several years, decades. It takes a long time to get global eradication anything. And we really don't have enough information to disseminate. We need to know, for instance, how bad is this infection in children just to get is it always a mild infection or not? We just don't know yet. We've been really pushing the elimination approach at a global level through the British Medical Journal and other publications. And so it's worth remembering that more than 20% of the world's population is protected with elimination at the moment. So it's a very viable approach. If something like Vietnam can do it, 100 million people, densely packed cities, long, complex land borders in China and other places, I think every country on earth could do this. So there's some implications for public health, and I think that's wider health of New Zealanders. I'll go through some of those about how we make decisions, how we adapt to future hazards, and I think you're going to continue. I think you've assumed a frontline role, which will be carrying on. Infrastructure, global health institutions, and I think seizing some of the positive opportunities from the COVID-19 response. So every disaster movie starts with the government ignoring the scientists. And fortunately, that was the opposite. That's what happened in New Zealand was the opposite from that. And that's my single biggest lesson from the last year and a bit, is having good science advice and courageous political leadership is a winning combination. If you have one without the other, it's not so good, of course. Now, so there's a long list of things here, but I really do think we need to improve our ability to make decisions in a crisis. Many of us have interfaced with the system and I think we can do better. I think trying to have systems of cross-party support is good. High-level strategic science advice, evidence and evaluation, I think this has been a real weak point for us. We've got a $30 billion response. Why are we not spending a lot on evaluating it? We're spending virtually nothing. Comprehensive information, it's very hard for journalists, scientists, and others to know what's going on from the outward-facing information. We just need to be an information-rich society. And a comprehensive review, I think, goes without saying. So, a second point, this is the idea of moving to an all-hazards approach. As I said, the greatest global weakness was that all our thinking was tied up with one hazard. We had a great plan for the wrong virus. So we need to do better. And the epidemiology is another 2x2 tables, so that's showing as you go up, it's higher case fatality. As you go to the right, it's more transmissible. So this, where they intersect is that the red zone, and that is flu pandemics, so non-seasonal flu, we know about that. Smallpox can easily be recreated and released again, will be devastating. Emerging disease X, that's zoonotic diseases. There's 20,000 plus coronaviruses sitting in the animal kingdom waiting to get us. And virtually none of them will ever do it, of course, but that's concern, and many other zoonotic threats. But also, what I'm more worried about now is novel synthetic diseases and the ability with gene editing and so on to create a very wide range of horrific viral and bacterial threats. So we need an approach that can deal with this full diversity of hazards. And I also think the other much worse hazards are around climate change, environmental destruction, because they're locked in for decades or for generations, unlike pandemics, which are transitory threats. And I think equity is a key threat, again, to our collective survival. We need to address that. It's a very detailed slide, but looking at infrastructure, I think this is a great opportunity to benchmark. Now we've got a link with Australia. Looking more widely, we spent a lot of time talking with Taiwanese authorities and written quite a bit about this, because Taiwan did even better than New Zealand. Very low case load, no lockdowns required, and they sustained elimination. And the big difference is they had a dedicated public health agency, and there were various other things. They worked very hard on mask use, digital contact tracing, and early water management. So again, I think we should look to the various in terms of benchmarking. I was thinking about the international people you're talking to later on. I mean, you should be talking to them, because the performance that you've produced in New Zealand is outstanding by world terms. And so you have a lot to teach the rest of the world. In terms of other infrastructure, again, that's quite a complex slide, but one of the observations I would have is that New Zealand assembled a national public health agency by taking all the essential functions and activities and basically forcing it all together, and it made it work. And so we think, well, what does a national public health agency look like? It looks like what New Zealand created over the last year or so. And I'm hoping, I mean, there is a commitment to a national public health agency. We will produce something like what we have assembled, rather than going back to the past, which is having a small isolated unit that's forgotten inside the government apparatus. We do forget these lessons very quickly. So another bit of infrastructure, quarantine facilities, obviously a very lively debate. Some of you may know that at Otago they're spending $250 million on an upgrade at the moment. You probably know more about this than I do. But it's not for quarantine, it's to house aircraft. So I do think, given the scene that we have in front of us in terms of risk, we should think about this. And these are very versatile facilities that can be repurposed at peacetime for other things. Australia's building at the moment. Screen's stuck in a different place. Effective global health institutions, we really need these. And today or tonight, the final report of this review that Hannah Clark's been leading, the independent review panel will release its report, which will be very hard-hitting about the fact that WHO needs to be reformed, because we have to have these agencies. And So there's a lot here, but I do think there are huge positive opportunities coming from the COVID reset. And again, this is saying all the things in green, which you'll have trouble reading, all the things that we couldn't do before we could suddenly do very quickly. Homelessness disappeared for several weeks in New Zealand. And the absolute dependence on daily commuting for many people changed, and we just did a whole lot of things differently. So just trying to take the good bits from the lockdown and the other experiences and saying, actually, it does show we've got a huge agency to change and change ways of operating and realising we don't need to do some things that have been part of our lives in the past. So the critical role of border protection, this is the part that I've been thinking a lot about before coming to see you. And really, at a high level, I think for me, as an outsider, thinking from a systems point of view, there are two key areas. One is always taking a systems approach to risk assessment and management. And the second thing, and I know you're all involved in continuous quality improvement based on investigating and learning from outbreaks and errors, and also timely, transparent reporting. I think everyone in New Zealand is invested in what you do. I just love to see the idea that every time we have this mere cultural approach to everything, we just get the stuff out there quickly, because that builds trust and engagement. And it's also a great way of communicating with everyone in your sector. Something went wrong, this is what we discovered, and this is how we're going to fix it. I mean, that's the kind of culture I think hopefully we can really represent and model. So just running through these basic, I'm realising given time I should go pretty quickly, but you're all familiar, risk is the universal currency that we're all immersed in. A probability that an event will occur, that's a very technical definition. Usually it's around the probability of a generally unfavourable outcome occurring. And many of you will have seen this is the standard matrix, this is a New Zealand standard, and it's just intuitively logical. It's saying the things to worry about are things that have a high likelihood and high impact, or high probability and high consequence. Now this is partly a tool for managing or prioritising what you do in your work. But if you, there is another component of risk, which is the more technical thing that an epidemiologist would do, is environmental health risk assessment. So this is more for feeding into policy. That matrix is no good for developing policy. You need a much more sophisticated approach. And that is where you're looking at the likelihood of adverse events that may result from exposure to specified health hazards. This is environmental health risk assessment. Just out of curiosity, does anyone in the room use environmental health risk assessment in feeding into policy? Is that something that, there's one hand goes up, and well, you are very present, two hands going up, because this is absolutely the core tool that quantitative scientists use for guiding policy development. And there is, I think risk assessors are actually quite scarce, but very important. So this is the kind of framework, I won't go through all of this, it's risk assessment, risk management. It's a highly evolved area of science. So risk management, that's what everyone is involved in. The steps taken to alter, I usually reduce the level of risk to an individual population. And it's also, this is another part, managerial decision-making and active hazard control processes to deal with environmental agents of disease. So they're just different flavours, there's many different definitions of this, but again, I'm sure everyone in the room is doing this on a regular basis. So one of the things here, I mean, there's, as you know, this field is full of key concepts, and this is actually something that's built into workplace safety, and this is from WorkSafe New Zealand. And this is saying that not all risk management tools are equal. There is a hierarchy. You start with eliminating hazards, minimizing them with substitution, isolation, engineering approaches, then administrative control measures, and bottom of the list, personal protective equipment. So what it's saying is don't start with PPE. You have to have it, but that's your last line of defense. That actually the really important stuff is before that. It's about system design, and it's far less usually about people making mistakes. I mean, it shouldn't be a disaster if people don't always follow the rules. the key thing is to engineer out the opportunity for human error as much as possible. So it's all about design. And just to say another key concept here, this is around the idea that we need to think in an integrated way about the entire traveller journey, pre-departure for 1 to 2 weeks, during the flight and transit, during quarantine, the bit that you obviously are very involved in, post-quarantine. We need to think in an integrated way about what are the most effective interventions to do at each stage. So that's a concept. So if we look at that, the pre-departure approach, this is still by far the single most important risk management step in this whole process. And this is the idea of, this is a traffic lights approach. And New Zealand, as you know, has recently moved from one size fits all at the pre-departure process to stratifying the world into 3 groups. You could argue about exactly what those strata are, but the green zone, quarantine-free travel; amber, you're still doing routine precautions; and the red zone, basically a huge reduction, turning down the tap of infected travellers. And this is by far the most important risk management approach for our borders. So I might go through this a little bit just to explain why the numbers really matter here. And it'll be hard to see at the back, but this is saying that if you have, this is looking at 3 sample countries. The numbers are not precise because I don't have the data to calculate them. But this is saying that the currently infection risk in, say, Australia is about 1 in 200 million. They have no quarantine barrier, and therefore the infection risk in New Zealand is still 1 in 200 million when they arrive here. And so 20 million, I mean. And that means about 1 outbreak every 10 years with quarantine-free travel, give or take 5 years or so, or even a bit more. From the UK, the source person is maybe about 1 in 1,000 people are infected, and then obviously they go through quarantine, and quarantine does not eliminate the risk. It reduces it about 200-fold. So at that point, they're about 1 in 200,000 risk, and then that means about an outbreak every 5 years. From India, it's got up to about 10% for some groups of travellers, and that means that reducing that with quarantine is still 1 in 2,000 risk, so you might get an outbreak every 6 months from that source. So the point I'm making here is that we're all in this risk reduction, risk management business, and as we always say, the ministers, everyone always says it's not risk-free, it's just about risk assessment and risk management. So just to finish up, this is, you obviously have a whole lot of methods that you use for, this is when you investigate something. So we've got epidemiological, laboratory, and other methods, site investigation, standard methods for investigating when things go wrong. And a point I wanted to get your feedback on is, how do we describe mistakes? And what I say firstly, the question is about agency. And there's a whole lot of different words. At one extreme, you can say a virus incursion. That's, as you can see, is giving agency to the virus. It's a tricky virus. The virus beat us. The other end is a border system failure or a warning event of some sort, where we're giving agency to you as the border managers. In the middle are really neutral terms like a border event, breach, leakage, which has not been so definitive. If there was more time, we could perhaps discuss that. As from an epidemiological point of view, or people involved in describing risk and when things go wrong, we have always defaulted to talking about systems failures, because it says actually something's going on with the system. We need to look at how we can make the system work better. Not everyone likes that, firm I respect, but if there's time, it would be interesting to get your views. But the other things here, what I'm suggesting is, we're asking you if you have a roundabout typology for describing when things go wrong, so everyone knows what you're talking about, it's consistent across your organisation, and we'd say it meets the criteria of being valid, useful, clear, consistent, and that your systems are all converging on describing when things go wrong the same way. And so we think about the type or scale of failure. It could be a border system failure or a border system hazard. It could be pre-travel, travel, or MIQ. Or we think also about the cause. Is it a design failure? And I would say it's almost every systems failure is a design problem, or is it a delivery failure, or is it a bit of both? And I think it is useful, if you have that kind of typology, hopefully it means you can converge on the critical thing, which is taking action to fix the problem. And again, I'm just about finished. This again will be hard to read, but this is what this is trying to say is, with a table like that, you can start to classify the things in red are actual systems failures, the things in amber are hazards. And so you've got a pre-travel infected person or infected on aircraft. They're not necessarily, they're hazards, they're not actual systems failures at that point. And then infected travellers picked up in MIQ, day 12 is getting maybe very indicative of potential systems failure. And then you try and think, is it a design failure or a delivery failure? So it's just trying to think, again, how an epidemiologist would look at what you're doing and try and classify things in a consistent way. So a public health triumph, nothing happened. So that's unfortunately the business you're in. But how will we know if our pandemic guidelines work? The world will think we overreacted. And what does it feel like? And I think there are 5 million stories about the last year and some of the weird and surreal moments. I mean, for me, one of the most surreal moments was going to see this play at Bats Inn. Did anyone go and see Transmission? I think it will be coming back. But this is based on a year of interviews with an old friend of mine, Stuart McKenzie, and he interviewed a few other people who had some role in the response and crafted this into a play. So I had to see another old friend of mine, Tim Spite, playing me, complete with every mannerism and playing speech pattern for 90 minutes. So just to summarise, I think elimination is the optimal response. I think the evidence is in. We need to prepare for far more serious threats on the horizon. I don't think we're going to be out of a job anytime soon. The critical thing is science and public health infrastructure, which again, you're part of the infrastructure. And border biosecurity is absolutely the most important thing we have to do right for sustained elimination. And as I'm trying to emphasise, from an epidemiology point of view, there are two things we have to do extremely well: risk assessment, risk management, and constantly improving design and delivery. And I've got a lot of great collaborators who I've been working with on this for over a year. And finally, it's useful to today.
Thank you, Michael. We've got about 10 minutes for questions or feedback on language. Give that a chance. And we've got a roving mic, so if you've got a question, maybe just say your name and where you're from, employment-wise or geographically. And so Michael will do his best to answer.
Hello, Professor. I'm Mel Child. I work in the MIQ operations area. Thank you so much for that. It was really thought-provoking and a nice reflection of how far we've come as well. I'm really interested in your thoughts on the future. How do we transition from where we are now with these stringent border controls? We know that there's vaccination, we don't know a lot about it, but how do we transition to a more normal sort of environment? Thanks.
Yeah, I think it's a great question, and I think we can do it quite easily because we look at how we manage. We've got examples like measles at the moment. Measles, you have high coverage. It's a much more transmissible virus, so you need to have 95% of the population vaccinated. With COVID-19, 70% will be enough. I think we'll get there. And so if you have a highly vaccinated population, you can open the borders. If you have an outbreak, you still follow up and you isolate in quarantine in the normal way, but it wouldn't be such a big deal anymore. And also you'll find across the globe, it's almost inevitable there'll be a vaccination requirement for travel, given the way things are going. So the risk of importing the virus will get less and less, and the rates in source countries will drop to very low levels. And then eventually you'll see the green zone, which is small at the moment, will become most of the high-income world by late this year, early next year. So I don't think it will be too difficult because there are models for doing this. I think the horrible part of all this is that low and middle-income countries are going to miss out on vaccines, will be down the queue. So we are going to see more India, unfortunately. So that's, I think, the grim other side of this. On that topic, I think it's absurd that we're having events like the Olympics at the moment, of course. I mean, the combination, huge amount of international travel and mass gatherings, that's just ridiculous.
More questions?
Thanks, Professor. Not so much a question, but for your call for typology and execution and good investigative techniques. I'm with the Aviation Security Service, so a lot of our investigations are based on James Reason's model of investigations, which is more around systemic, looking for the systemic failure rather than the individual failure. And we talk about errors and slips as opposed to mistakes or failures, and so we're looking to why the individual was allowed to fail rather than why did the individual fail. And that seems to me be pretty much what you were actually proposing about. And I think if we can move into that model, and it is difficult because it requires an open and mature reporting system of incident occurrence as well, which is not always comfortable for an organisation. We can get ahead of the game and be far more proactive in managing those incidents and occurrences as they occur. So yeah, I agree.
Thanks. I would say the aviation industry is world leaders in this. You do it very well.
Thank you. I'm Jane Wallace. I'm with the Ministry MIQ team. The global institutions, interested in your view on what role WHO's resistance to the idea of aerosolization as transmission sort of contributed to what's happening globally and why that resistance is happening.
Yeah, look, I found the World Health Organization very mysterious during this pandemic. New Zealand succeeded by doing exactly the opposite of what the WHO said we should do. They said keep your borders open, don't use masks, and then use lockdowns as a last resort. New Zealand did the opposite. Shut our borders, use lockdown at the beginning, and eventually use masks outside healthcare settings. So I think that that's part of that syndrome of WHO being very resistant to new ideas. And I think part of it's just very poor critical mass to keep things going. So yeah, very good point, totally agree.
One more question.
Kia ora, Michael. Pete Watson here from Counties America THP. I'm really curious about why masking hasn't taken a hold in New Zealand culture. Even within the DHB culture where there's people you would expect would get it, there's been a significant resistance to sort of adopting that as a culture where we're doing it. And to me, as somebody who uses public transport a lot, I can still attest to that variable use of masks, even when it's mandatory. I'd just be interested in your thoughts.
Yeah, I think it's a bit like the behaviour of the World Health Organization. Our institutions have not embraced mask use and built it into our systems. Even our alert level system, we put forward an alternative proposal for refining it, would make much more use of masking and much less use of stay-at-home orders, because you can actually keep society operating. That's one of the benefits of masks for much longer with small outbreaks. But the system is very resistant, and I don't know where that's coming from. I don't know if anyone else here has any special insights into why there's almost a total blanket resistance to mask use in our institutions in New Zealand. And it's right at every level. It's a mystery to me because the evidence has been compelling from quite early last year that this was largely aerosol borne, and yet the whole message was wash your hands, sanitize for months, and when it should be mask up and ventilate right from the beginning. And the evidence was just compelling. Does anyone have any theories about this? I do not know.
Hi Michael, I'm Michael as well, I'm the Equal Librarian for NRHCC in Auckland. I've spoken to a lot of the people that are fairly misinformed coming from overseas regards to the mask side of things for one of the things that they're upbeat about. But I think what the latest thing that we felt that we've sort of had to deal with is that they go onto PubMed, they type in mask bad, and they essentially quote the different articles that are in support of it. One of the most recent ones that I've read is something like 30 or 40 pages as a sort of meta-analysis of all these studies that are done about the harmful impacts of masks and hypoxia and hypocapnia, so low oxygen, carbon dioxide. It's very hard to actually refute that because it requires a tremendous amount of time and an expertise that I don't possess. So I'd like to know how you would sort of help deal with those situations. Yeah.
Well, in this instance, yeah, I mean, misinformation, disinformation are a huge issue, and we could talk for a long time about that, but I actually think it's different with mask use. It's our institutions have not actually embraced mask use, and unlike washing your hands, you can tell if someone's wearing a mask or not. It's actually quite easy to institutionalize mask use, and we haven't done it. And across at the highest level, we've not embraced mask use in New Zealand. So I think misinformation, misconceptions has some role, but I think it's quite a global thing in New Zealand. So I think it's something we could learn from the Asian response, and some of the most effective responses in the world have been based on mass masking.
I think one very last question, isn't it?
Jess Vance from the DHB. I'd like to know how you were talking about that COVID needs to be thinking more broadly about other things as well. And I think what we've seen is a health system under abuse. And somehow, we have eliminated COVID relatively successfully, but when we look at our health system, it's somehow lost. And we're seeing that right across the board with the health system. So how do you propose we start looking more broadly about how we lift our health system to be able to respond in a more responsive way?
Yeah, well, again, I think COVID has shown the way that you have to have evidence about what works and what's important, and then you have to have a government system that can apply that systematically, and then you have to bring the community and the public with you. So you get all those elements right. I think the revised health system has some positive features about doing this, but again, as we know, it's not about structure, it's about how they ultimately function more than anything. It's a great question, thanks.
Thank you, Michael. Thanks for getting us thinking straight up in our two-day forum. I really appreciate you closing a few ideas, and we will pick some of these up. We do have an international panel next, but you've really set the scene nicely, and I think you can stay for the international panel. Oh, no, yes, I can. It's not that you're allowed to. You're welcome to.
Oh, thank you. Wow.
We've got about 4.5 minutes before we kick off the international panel with a degree of technical difficulty of about a 9 on this one. Let's just stay calm. You want to refresh your glasses, as Jim says. Now it's the